For the first couple of chapters, you want to review from your anatomy and physiology a couple things, including what a joint is, what a muscle is, different types of bones, what the purpose of bone marrow is and what it produces, and the structure of bones. There are 3 cell types you need to be familiar with in regards to bone formation. The first is osteoblast. This is a cell that secretes a matrix for bone formation. Osteocyte is when that cell becomes a mature bone cell. Osteoclasts are bone reabsorption cells. Remodeling is when the old bone is removed, and that's called reabsorption, and simply when new bone is added to the skeleton, and that is called formation. There are factors that affect the rate of remodeling, and those include if a patient is engaging in weight-bearing activity and if they're getting enough calcium and vitamin D in their diet. There are 3 types of joints that we would like you to be familiar with. The first is the Synarthrosis joint, and that is an immovable joint such as the skull. The second is the Amyarthrosis joint, and that provides limited vertebral movement. And the third is diarthrosis joints, and those allow free movement such as with the hip or the shoulder. It is also known as a ball and socket joint. As you are reviewing what you learned in anatomy and physiology, be sure that you include looking up ligaments, tendons, and bursa so you are familiar with these terms. You can review body movements on page 1120. Be sure that you are familiar with what adduction and abduction mean, pronation and supination. Whenever you see any gerontological charts throughout your reading for Nursing 102, be sure to read them. There is one on table 39-1, age-related changes of the musculoskeletal system. When you are assessing the musculoskeletal system, you will use inspection and palpation. It's important to get a complete health history of the patient. And there are a couple terms that you would need to know during your assessment if it's applicable to your patient. The first is scoliosis, which is a lateral curvature of the spine. The second is kyphosis, which is an increased convex curvature of the thoracic spine. And lordosis is an increase in concave curvature of the lumbar spine. Your patient's bone mass peaks at age 30. Also, it's important to know as you're doing your assessments of your patients to look at their neurovascular status, and this basically means if their circulation is adequate. And to do that, you want to do Cms checks. C stands for circulatory. You can check that by their skin color. M stands for motor. You can assess the patient's capillary refill, pulse, and strength. And then sensation is S, and that stands for paresthesia. So again, that's CMS checks to check the neurovascular status of the musculoskeletal system. Also, it's important if it's applicable to your patient, if they have a surgical incision site, you want to be checking that regularly. At the beginning of your shift, it's important to get a marker and mark where the drainage is at that point so you can monitor the progression of the drainage throughout the shift. It's also important to note that the surgeon always does the first dressing change. So, for example, if you had a surgical incision site that had excess drainage, you would just want to go ahead and reinforce that until the surgeon was able to do the first dressing change so they can assess the progress. A focus pain assessment will be included on the next exam. A focus pain assessment does need to include all of the factors that I'm about to mention. This is something that you can do in clinical when you're giving a pain medication, for example, during your assessments, during your vital signs, checking to see how the pain medication is working for your patient. So that would include the provoking factors or the cause of the pain, the quality of the pain, whether it's stabbing, pressure, or heavy, the region that the pain is in, and if it's radiating anywhere, the severity or intensity, which is typically measured on a 1 to 10 scale, and then the timing of the pain. Is it continuous? Is it intermittent? Is it acute? Is it chronic? The 5 Ps help assess the neurovascular status of your patient. If there is increased pain, that could be a sign of decreased circulation. If there is a decreased pulse, that can be a sign of decreased circulation. If there is pallor, if it appears to be dusky or blue, or kind of a whitish color, that can be a sign of decreased circulation. If there is paresthesia or feeling present that include burning, tingling, crawling, restlessness, or a crampy feeling, that can be a sign of decreased circulation. And finally, if paralysis is present, that can also be a sign of decreased circulation. There are some diagnostic tests that you need to be familiar with. The first are different serum labs that will be drawn on your patient. The first of that is the complete blood count. I don't need you to know at this very point in the semester the exact values of the CBC, but you do need to know what it is composed of, and that includes the white blood cells. So for example, if the white blood cells were elevated, that can indicate infection. It also includes hemoglobin, hematocrit, platelets. If those happen to be lower, that could indicate some sort of hemorrhaging. Calcium is something you want to take note of, as well as the vitamin D levels for these patients. And then also CK or creatinine kinase. If that is increased, that can indicate extreme muscle breakdown. An X-ray provides a one-dimensional scan of bones or joints and can be helpful, for example, in initially diagnosing a fracture. A CT scan, on the other hand, it's a more detailed cross-sectional image of the body. It can be given either with or without contrast. If it is given with contrast, it's extremely important that you make sure that your patient's kidneys are in good working order, and the way that you would do that is check their serum BUN and creatinine levels. Make sure that they are well hydrated. If a patient does decide or does get a CT scan with contrast, often you will see physicians order Mucomist to take to help pass that contrast. So the generic name for that, I'm going to spell it for you, ACETYSTEINE, and then the trade is Mucomist, and that helps to pass that dye safely. The MRI is a high-resolution image of bones and soft tissues. It is absolutely incompatible with any sort of metal inside or outside of the body. Typically, you complete a checklist with your patient to make sure that that's not the case, because if that is the case, if they have some sort of implant, for example, they cannot get the MRI. Also, the MRI is incompatible with shellfish and iodine. Arthroscopy is an invasive procedure. It allows direct visualization of a joint through a fiber optic endoscope. and this can be helpful for various joint diagnosis. It would be expected that the patient would be stiff afterwards. You would want to report if there is any sign of neurovascular compromise or infection or delayed wound healing. Arthrocentesis is also an invasive procedure. It is a joint aspiration of infectious drainage, and that can be done to increase the patient's mobility, and it can also be done to actually test that drainage. Electromyography that assesses the muscles for any weakness. A biopsy is gathered as a sample to determine structure and composition of bone marrow or muscle. A bone scan is a radioisotope given through an IV line. It's very important that the bladder is empty at the time of the scan so that there is a complete pelvic view. Afterwards, it's important to give patients fluids so that the isotope can be flushed out of their system. The bone scan can be used to detect metastasis, bone tumors, and osteomyelitis, which we will discuss later on in this lecture. Casts are best used to immobilize fractures. It's very important to immobilize the joints proximal and distal to the injury. There are a couple types of casts. The first is fiberglass, that is quick to dry. Plaster casts are slower drying. They can actually take 24 to 72 hours, but they are movable and moldable. However, they are not water resistant. Throughout this class and your time in nursing school, whenever you see a section that talks about educating the patient, it is very important to read that section in your textbooks. Those are heavily tested on NCLEX. So as far as cast care and what you want to educate the patient on, you don't want to get the cast wet. You don't want to slide anything into the cast. You want to make sure it's elevated or on a sling. And then it's very, very, very important. If you have a patient who has pain that is uncontrolled by analgesics or elevation, you need to let the physician or surgeon know that immediately. It could be what is called Compartment Syndrome. This occurs when there are increased pressure in a confined space. There is pressure on tissues and nerves, and if ischemia occurs, this can cause irreversible damage. Okay, let's talk about splints and braces. Splints are used for simple and stable fractures. Braces are used to provide support, control movement, and prevent additional injury. An external fixator is when hardware is inserted into the patient's bone. It manages complex open fractures with soft tissue damage. Some advantages of an external fixator is that there is immediate stabilization. Some disadvantage is very much an increased risk of infection. It could turn to osteomyelitis, which we'll discuss later in this lecture. It's very important to note that you do not want to cross-contaminate the pins. So for example, if you had a swab with the cleaning agent on it, you can clean one pin site, but then you want to discard the swab and then go to another pin site to clean that with a separate swab. You would never want to blow the site dry. And you want to make sure to assess neurovascular status often for these patients. Traction is used to maintain alignment after an injury. It can decrease deformity and spasm. It can be used as a treatment method in and of itself, or it could be used short-term until the patient is a candidate for surgery. There are two types of traction that you'll need to know. The first is skeletal traction, and that is actually when the hardware is put into the patient's bone in an aseptic manner. Skin is traction that has an apparatus around the skin only. For example, Buck's traction is skin traction to the lower leg. For both types of traction, it's really important to make sure that this traction does not touch the floor or isn't impeded in any way, because that would cause misalignment in the healing bones. Important nursing care includes assessing for skin breakdown, turning Q2 hours, cleaning the patient, assessing skin, especially bony prominences. You also want to assess for DVT or deep vein thrombosis. If a patient had a deep vein thrombosis, that would present as tenderness, warmth, redness, and pain. In order to prevent a patient from getting a DVT, you would give Lovenox as prescribed, help the patient with range of motion exercises, ambulate as able. You can put sequential compression devices or SCDs on your patient, and TED hose. Nurses also assess their patient for likelihood of skin breakdown at least every shift using the Braden scale. And this looks at things such as how often the patient's incontinent, how well they're able to move, how well their nutrition is, and assesses their likelihood to have skin breakdown and any preventative measures a nurse can do. We are going to discuss joint replacements. Another word for replacement is arthroplasty. An arthroplasty is replacement of the joint with metal or synthetic materials. A total hip arthroplasty, it's very important to note that after the patient goes through this surgery, they will have what is called hip precautions. And a good way of remembering those is the acronym TLC. T stands for turn. Do not turn the affected leg inward. L stands for lean. Do not have the hips bend over 90 degrees. C stands for cross. Do not have the patient cross their legs. To prevent these things from happening, an abductor pillow is typically used in addition to having raised toilet seats for the patient. It's very important to note the indications of a hip dislocation. That would include one leg being shorter than the other, increased pain, external rotation. Also, it's important to note that these patients with a total hip arthroplasty are expected to have up to 500 milliliters of drainage in the first 24 hours. However, if it was greater than 500 in the first 24 hours, you would want to notify the surgeon. Because this is an invasive surgery, there are some common concerns that you would have amongst any surgical patient. That would include monitoring for DVTs, as previously discussed in this lecture. You would also want to monitor for infection, which could include fever or chills or increased white blood cells. Typically, an antibiotic is used preventatively. Then if we want to talk about total knee arthroplasty, in addition to monitoring for the complications that are mentioned above, it's important to know that these patients, they would want to use a CPM or continuous passive motion device, and this allows some range of motion for their knee after the surgery. It is always the the surgeon that makes the determination of degree of the CPM and advances that accordingly. It's important to know as well that if passive range of motion is ordered, the caregiver performs that. If active range of motion is performed, the patient does that. Some other considerations that you need to take into account is if you have a patient that is obese and they have gone for any of these surgeries, they do have a risk of delayed wound healing and a risk of the wound dehiscing. Also, geriatric patients have an increased risk for hypothermia. This is a reminder to use good body mechanics while you're in clinical. That would include lifting predominantly from your legs, making sure you get help when you need it, and use the proper lift equipment. Carpal tunnel syndrome is a short section in your textbook, and it is a self-study, so take some time to look over that. Ganglion is also a self-study and a very short read. Osteoporosis is when the bones have become porous and there is a thinning of the bone. This makes the patient more susceptible to fracture. The risk factors include decreased calcium and decreased vitamin D intake. The recommended amounts of calcium are 1,200 milligrams, and the recommended amount of vitamin D to help absorb the calcium is 800 international units. If the patient is postmenopausal, that's also a risk factor for osteoporosis. If they are a woman, sedentary, obese, or take corticosteroids. Osteoporosis is diagnosed by a bone density scan. Patients with osteoporosis need to be sure to get enough calcium in their diet. They can do this by eating broccoli, yogurt, cheese, salmon. They could drink low-fat vitamin D milk to help with calcium absorption, which the vitamin D would provide. Another way you can get vitamin D is through sunlight. It's also very important that they engage in weight-bearing exercises at least 3 times a week. A good way to start is walking 20 to 30 minutes at least 3 times a week. Medications that these patients can take include calcitrol. That's a calcium supplement, and that is the generic name for that medication. Another medication that they can take is ibandronate. That is the generic name. The trade name for that is Boniva, and that just basically helps to strengthen the bones by slowing bone loss while increasing bone mass. Although you are not in pharmacology, we will point out important medications that you need to know as you learn about various disease processes in MedSurg 1. We have hit on all of the subjects listed here under osteoporosis, but do be sure that you are familiar with the pathology, the assessment, diagnostics, nursing care, and medical management. Osteoarthritis is a non-inflammatory degenerative joint disorder. It is characterized by pain and stiffness in the morning. Patients that are most likely to have osteoarthritis are older patients, female patients, and patients that are overweight. It can be diagnosed by an X-ray. Nursing care for these patients include gradual increase in exercise to reduce weight, pain management, and improvement of joint mobility. Medical management includes NSAIDs for pain management, increased range of motion, and increased exercise. Osteomyelitis is infection of the bone. It is most commonly caused by the pathogen Staphylococcus aureus, and that pathogen will invade the tissue surrounding the bone and then proceed to the bone itself. Osteomyelitis can be acute or chronic. Acute osteomyelitis is effectively treated with IV antibiotics. Chronic osteomyelitis is more difficult to treat. Often surgical debridement is used where the necrotic tissue is excavated in a surgical setting. Osteomyelitis is the infection of the bone. Its most common cause is Staphylococcus aureus. The patients that are most at risk for osteomyelitis are patients who are obese, poorly nourished, patients who are taking corticosteroids or immunosuppressants. And it's also important to note that patients who have peripheral vascular disease or diabetes, both of these disease processes interfere with the patient's ability to heal. Therefore, they are at an increased risk of osteomyelitis. Infectious sources that could cause osteomyelitis include, but are not limited to, traumatic injury, surgery, intravenous drug abuse, presence of a prosthetic device, chronic joint disease. It's very important to think prevention of osteomyelitis because it is quite difficult to treat if an infection goes to the bone. So for example, in surgery, antibiotics are given preventatively before surgery starts. For our diabetic patients, we want to really emphasize good foot care. We want to prevent a patient from getting a pressure ulcer because they are at great risk for osteomyelitis in that case. Also, when you are sending a surgical patient home, really take the time and make sure that they understand the signs and symptoms of infection of that surgical site. So if they're receiving fever, chills, redness, warmth, any delayed healing, they need to call the doctor's office and let them know about it. If a patient has osteomyelitis, they would present with a fever, especially if it is a blood infection, pain, tenderness, swelling, redness, and warmth in the affected area, irritability, just not feeling well, and difficulty moving the joint and bearing weight on the joint. Diagnostics include blood work, looking at that CBC we discussed, seeing if the white blood cells are elevated. You'd also want to look at the ESR serum test. If the ESR is elevated, that can be a measure of inflammation. An X-ray can do preliminary work to see if osteomyelitis is present. And it can also indicate if further assessment needs to be done through a bone scan, an MRI, or a bone biopsy. Nursing care for osteomyelitis would include pharmacological and non-pharmacological interventions. Non-pharmacological interventions would include different positioning for the patient, helping them with guided imagery, using heat or ice intermittently. Pharmacological interventions would include analgesics or pain medications. Also, the nurse could assist the patient in range of motion. Medical management would include monitoring for further signs of infection, again, looking at the temperature or white blood cells, assessing for other signs and symptoms of infection, including warmth, edema, and surgical debridement, as we mentioned before. A contusion is a soft tissue injury caused by blunt force, causing blood vessels to rupture. A strain is an injury to a muscle or tendon from overuse. A sprain is a torn ligament and tendon that surround a joint. For nursing management, you want to think RICE. RICE stands for rest, preventing additional injury. I stands for ice, so you want to have intermittent ice on the injury, producing vasoconstriction. C is compression. E is elevation at or above heart level. However, it's important to note if there is any sign of decreased circulation to that injury, you want to keep it at the heart level to make sure that you do not compromise the arterial blood flow to that injury. If a joint is dislocated, it will present as acute pain, deformity, a change in contour. The limb length will be shorter on one side versus the other, and there will be a loss of mobility. It's very important to immobilize the joint on the way to the hospital and perform neurovascular or CMS checks as discussed previously. If a patient has a rotator cuff injury, they are going to go to physical therapy. Therapy is considered tertiary care, and it's important to know when a patient does go to physical therapy, they are trying to achieve the optimal or maximum functioning that is allowed. Other management includes rest, decreased mobility, pain medications, and it is important to note that their physical therapy exercises can last up to 12 months. A fracture is marked by sudden pain. That's why we have ouch there. Also, there should be loss of function, deformity. There could be crepitus, localized edema, and shortening of the limb. It's important as you are assessing your fractures always to do neurovascular checks and to check the pulse distal to the injury. So for example, if you had an upper extremity injury, you want to check the radial pulse. If you had a lower extremity injury, you would want to check the pedal pulse. When reviewing the different types of fractures, it is important to note the difference between an open fracture and a closed fracture. A closed fracture is when there is no break in the skin, and an open fracture is when there is a break in the skin, and that puts the patient at increased risk for infection. Again, it is important to understand the difference between closed fractures and open fractures. If you did have a patient that had an open fracture, you would expect to be giving antibiotics, doing cleaning and debridement of the wound, and also give a tetanus shot prophylactically. The following complications can be caused by a cast or any traction device or fixation device that we have discussed today. Compartment syndrome we have already discussed. As a reminder, damage from this is irreversible, so be sure to review that. Fat embolism is a fat globule that blocks blood supply. It is caused by a lack of mobility or movement. Signs and symptoms of a fat embolism include hypoxemia, tachypnea, which is rapid or shallow breath, neurological compromise. Later, you're going to see a petechial rash or confusion, and we have already discussed how to identify a DVT and how to prevent one from happening. Again, active range of motion is when the patient does the range of motion by themselves, and passive range of motion is when there is assistance. These are some things to keep in mind if you're doing passive range of motion on a patient. Most importantly, make sure if the patient is nonverbal that you are assessing for nonverbal signs of pain, such as facial grimacing. An amputation is removal of a limb. We are going to discuss the below the knee amputations and above the knee amputations and some complications that go with that. The first thing you want to note if a patient has had an amputation is if they complain of pain in the amputated section, do take that seriously. It is very real to the patient, and it is caused by the severing of peripheral nerves, and it should be treated with analgesics appropriately. You should also wrap the stump before swelling starts. Typically, patients are going to go to rehabilitation after an amputation. It is very important that the rehabilitation team help promote the highest level of functioning possible for these patients, and they can help them graduate to use of prosthetics. Some nursing diagnoses that would be appropriate for these patients would include risk for impaired mobility, decreased mobility, self-care deficits, pain, and risk for decreased peripheral vascular status, or the 5 Ps or the CMS checks that we have discussed, which again are all looking at circulation. So if a patient has had a body limb that has been they have lost, you want to go ahead and go to the next distal pulse to assess if circulation is still occurring.